Hey everyone, I'm your host Adrian. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. Welcome everybody to today's Rupa Live class presented by Rupa University, the best way to learn about specialty lab work from industry experts. If you joined a little bit earlier, you might have saw that little GIF that was rotating back and forth. Those are the types of things that you can find on Rupa University, things like paid boot camps, things like these free classes. But my name is Adrian Martinez. I will be your host for this afternoon. Today we have a very, very special guest in Dr. Ralph Esposito, here to discuss advanced lipid testing, risk reduction for cardiometabolic disease. Before jumping in, a couple of quick housekeeping items. Everyone joining will be muted by default, but if you have any questions, please use that Q&A button down in the menu bar, and we will host a live Q&A session at the end of the presentation. Immediately following the Q&A, yours truly will show you exactly how to order these tests directly on Rupa Health. And if you have to jump early, no worries at all. We always record these sessions, and we'll go ahead and send it out to you. Additionally, you can find it on rupauniversity.com within the coming days. And finally, if you are a fan of this type of content, be sure to check out rupauniversity.com to get access to all the previous sessions that we have done. So with that, let's jump in. I'd like to introduce Dr. Ralph Esposito. Dr. Esposito is a naturopathic physician and certified functional medicine doctor with additional degrees in acupuncture and Chinese medicine. His personalized style incorporates the art and science of medicine to solve complex health issues, focusing on prevention and risk reduction to improve both health span and lifespan. I love it. Thank you so much for joining us today, Dr. Esposito. I will go ahead and let you take it from here.
Thank you, Adrian, and welcome everybody. In a moment, I'm going to start sharing my slides where we're going to talk about cardiovascular disease. How do we really assess risk using lipid testing, basic lipid testing, and advanced lipid testing. And from there, we'll go into some interventions that you use, both pharmaceutical, nutritional, lifestyle, all of the above. But what's most important is that if you understand why this happens, we're going to go a little bit into the why, then into the how to address it, and then we'll move from there. So let's start off with our slides. Okay, so a little bit of the learning objectives from today. This is really, we're going to be talking about cardiovascular disease, atherosclerosis, insulin resistance, because you cannot talk about the former two without including the last piece, which is insulin resistance or insulin sensitivity. We're going to talk a little bit about the biomarkers, advanced and basic lipid biomarkers, everything from a basic lipid panel to more advanced testing. Depends on what you consider to be advanced, but usually the ones that are more atypical. Talk about the metabolic markers when it comes to cardiometabolic disease, from cardiovascular disease, also insulin resistance. I will sway away from talking about diabetes, but as we can all understand, insulin resistance is essentially a precursor to diabetes. Hopefully we can prevent people from getting there. And then we're going to talk about pharmaceutical management if you are in a state or that's part of your modality. And then we'll talk about some interventions with nutrition, lifestyle, exercise, nutrients, etc. What's really important is that we understand what lipids are. So if nothing else from this conversation, I will teach you that you can't say good or bad cholesterol. That is one thing we cannot say. Cholesterol is its own thing. We have esterified cholesterol and unesterified cholesterol. LDL, which we often call a bad cholesterol. One of my biochem professors called it lousy cholesterol. We won't say that here, but that is not cholesterol. That's a lipoprotein, which has cholesterol in it and also has triglycerides in it, a bunch of other things as well. We're going to talk a little bit about the basics there. But what's really important to understand, and as you can see, esterified cholesterol, CE, which is cholesterol ester, and then we'll talk about unesterified cholesterol. So we're going to talk a little bit about that when it comes to some of the nutrition interventions. Lipoproteins, these are the major lipoproteins that we're going to be discussing, plus their remnants. Triglycerides, very important, especially when we come to the conversation of insulin resistance. VLDL particles, LDL particles, HDL particles. These are the lipoproteins found on these particles. So ApoB100 will come up very often. ApoE, which many of you are familiar of the genotype. We're going to talk about how perhaps the genotype has an impact on the actual apolipoprotein. ApoC, there's multiple of them. We'll talk mostly about ApoC3. And then on the HDL particles, ApoA1 and ApoA2. Lipoprotein little a. Another thing that we'll come away from, you will never say ApoA, it will be apolipoprotein little a or apo little a if you're going to be referring to lipoprotein little a. There's a big difference, especially when it comes to clinical assessment and risk assessment. Triglycerides, they exist without a lipoprotein. So essentially they're floating around the blood. Many docs will say it's the fat in your blood, it's the fatty acids in your blood attached to a glycerol. But I don't want to get caught up in semantics here, but it's important to understand that they are floating around in the lipoprotein, so in the LDL, VLDL, IDL, chylomicrons, and then also freely. And then we have lastly, the chylomicrons, which we don't really test for, but important to understand the physiology there. So this is a lipid or a lipoprotein. So on the outside, we have the lipoproteins, and lipoproteins are necessary to make fat more soluble because fat or oil and water don't mix. The LDL particles are essentially a fat or a lipid. So in order for them to be transported around the body, we need lipoproteins. So depending on the lipoprotein that exists or that we're discussing, we'll talk about the protein that's attached to them. Again, we'll talk a lot about ApoB, but also ApoC, ApoC3, ApoE, etc. On the outside, we'll have free cholesterol. And then on the inside, we'll have cholesterol esters or esterified cholesterol. Well, that'll be really important as we get to talk about the function of VLDLs, IDLs, etc. And then also on the core would be the triglycerides. It's really important to understand that when we're talking about a lipoprotein, this is really essentially what we're discussing. Not cholesterol, right? So this is not cholesterol. Cholesterol is on the inside and also on the outside, so on the surface and also in the core of the lipoprotein. This is essentially a breakdown of the cholesterol ester, which is again at the core, and the triglyceride makeup of different lipoproteins. And you can see as we go down from chylomicrons to chylomicron remnants, all the way down to Lp(a), you can see the triglyceride content decreases and the cholesterol ester content increases. So one thing that's not here that we will discuss is HDL. Many of you know as HDL as a reverse cholesterol transport. It has to do with its interaction with LDL particles, converting or exchanging triglycerides with cholesterol esters. We'll talk about why that's important and perhaps why or why not you may want to actually be using HDL as a risk assessment marker. I'll leave that as a cliffhanger. As you'll get towards the end of the lecture, you'll learn how to use it. So as you can see, the LDL is a cholesterol ester rich, whereas mostly vacant of triglycerides, or we would like them to be, relative to a chylomicron, which is really from, it's made from the fats that are from the enterocyte, from your gut, which then makes a chylomicron, attaches ApoB48. That might be the only time that we'll discuss ApoB48. From here on out, when I refer to ApoB, we're referring to ApoB100. So this is after the ApoB48 exits the enterocyte into the lymph, goes to the liver, and then the liver turns that ApoB48 into an ApoB100. It's essentially half the size, or a little bit less than half the size of ApoB100. So the 48 really relates to the size. Very important when we're coming down to cardiovascular risk and risk assessment. And you can see down here, apolipoprotein little a, which is on the lipoprotein little a. So not, and if you see ApoA as a capital A, that's a different lipoprotein, different risk assessment. We'll talk a little bit about why that matters. So here are more of our apolipoproteins, and we'll talk a little bit about their action or their function. So ApoB is found on VLDL, LDL, IDL, and Lp(a). It is also found on chylomicrons, but again, that's ApoB48, and they have a residence time, a very short residence time, which basically means they don't exist in the blood for very long, and then they get metabolized into the liver, and then whatever the liver wants to do with them after will, as it excretes or secretes lipoproteins, those will have ApoB100. And depending on the type of tissue, ApoB will bind to LDL receptors. And we're going to talk a lot about LDL receptors and why that's important when it comes to risk assessment and intervention. ApoE, this is not the genotype. This is not the ApoE gene. This is the ApoE lipoprotein. The genotype does have an impact, we suspect, on the function of the apolipoprotein E. But you can see ApoE is one of the major ligands for the LDL receptor. So it's involved in the clearance of chylomicrons, VLDL particles, IDL, HDL. ApoB100 is the only lipoprotein found on LDL. LDL does not have any other apolipoproteins. Then we could talk a little bit about later on why ApoB is very important. But one thing to understand, and we'll come back to this, is that ApoE helps increase clearance of lipoproteins. So it helps the liver take up these lipoproteins, bring it in, metabolize them, do whatever it needs to do with them, which is going to be influenced largely by the what I call the metabolic microenvironment. So essentially whether somebody's insulin resistant or not, which is also influenced by their diet, their lifestyle, their muscle mass, etc. And what ends up happening is that then where we have ApoE binding to LDL receptor brings in cholesterol, which are on the lipoproteins, and that may have an impact on the LDL receptor expression, which in response then causes hyperlipidemia or elevated lipoproteins in our blood. We'll talk about why that happens, and if it's clearing more, then why would it cause more hyperlipidemia? There's more function onto that, we'll get onto in future slides. Also very important to understand ApoC3, apolipoprotein C3, there's C2. C3, it inhibits lipolysis, it inhibits lipoprotein lipase, which essentially means that it's preventing fat from being broken down that are found on the lipoproteins. So if you're inhibiting lipolysis, you're delaying how much they're cleared. So these lipoproteins, especially VLDL, and that's going to be very important as we discussed, is going to exist in the plasma longer. If you have any background in statistics or biology, or maybe this is a hobby of yours, area under the curve is going to be a term that I'll use pretty frequently. What we want to do is reduce the area under the curve, so essentially reduce exposure over life. So what increasing the residence time does is it increases the area under the curve, which essentially means more exposure. So ApoC3 is upregulated in insulin resistance. We believe that it might be a function of insulin resistance, and also a cause of insulin resistance. This is not something that we can measure. We don't measure ApoC3 in the blood aside from experimental environments or trials. And we also don't test ApoE, the lipoprotein. We can check the genotype, but ApoB, we certainly can, and that can be found in multiple different labs. Triglycerides, I think it's one of the unsung heroes when it comes to cardiovascular disease, assessing risk for cardiometabolic disease, glycerol, and 3 fatty acids. And this will be very important to understand as we come into understanding why would our dietary interventions have an impact on triglycerides, and why don't fat or having a high fat diet, such as a ketogenic diet, why doesn't it have a significant impact on triglycerides? And if you are a clinician, you know that if you want to reduce somebody's triglycerides, step one is you want to go after the carbohydrates. And on these triglycerides, we have an FN1, 2, and 3 location. And depending on the type of fat, the type of fatty acid that's attached to the glycerol, you can refer to it as attaching to the FN1 or the SN3 location, which might have an impact on its function and its risk. But in general, more triglycerides are a bad thing. So we're going to talk now a little bit about lipid metabolism. Why is it important? And how do we utilize the physiology of lipid metabolism in understanding risk and then interventions? So we'll talk a little bit about lipid or cholesterol synthesis, reabsorption. Many people refer to it as absorption, both kind of, but more reabsorption, hypertriglyceridemia, elevated triglycerides, and LDL particle clearance. These are the 4 factors that can help you assess cardiovascular risk and why somebody might have hyperlipidemia. We can assess or test for 3 of these. We can't really test for the last one, but we can use it as a process of elimination. But in the end, what's most important to understand is that a majority of hyperlipidemia really comes down to LDL particle clearance. That's kind of the end result. All of the other things do contribute to it and can make LDL particle clearance worse or better, but that is essentially the necessary step in determining whether we have cholesterol in our liver that's being eliminated into the bile, into the stool, or if it's going to sit around in the blood and potentially contribute to atherosclerosis and cardiovascular disease. So this is an important slide, bringing you back to Biochem 101, understanding cholesterol synthesis. Starts with acetyl-CoA. As we know, HMG-CoA reductase, this is one of the rate limiting steps in cholesterol synthesis. And we know that this is where statins work. But what's really important to understand is that there's a whole process here that allows us to understand cholesterol synthesis. And we're going to talk about two markers here, desmosterol and lithosterol. We're going to talk about two other sterols, which help us assess cholesterol synthesis and reabsorption. But when it comes to cholesterol synthesis, we know that if we can manipulate this pathway and perhaps inhibit it in some ways via nutrition, via nutrients, via pharmaceuticals, we can have an impact on the outcome, which is essentially the cholesterol. And this is the cholesterol that's made in the liver. A majority of the discussion that we're having today, biochemically, where does it happen? Where does it live? Fat cells and the liver. Very little in the muscle cells, and we'll talk about like LPL and lipolysis. In the endothelium as well. I already mentioned enterocytes. We can't forget about the gut. That's essentially our first interaction with the outside environment. So it'll be important to understand that, to understand the pathway. Save this, screenshot it, make sure you go back to it, memorize it, all of the above. It's going to be very, very important. Another way to look at it that I want to make sure we understand is that inhibition of cholesterol synthesis can also inhibit CoQ10 production, which we know is essential for the electron transfer chain in the mitochondria, which we need to make energy, ATP. So in essence, inhibiting cholesterol synthesis may potentially also have an impact on CoQ10 production. So as we're going through some of our interventions, don't forget about our good buddy CoQ10 and our mitochondria. As we know, many of the sources of chronic disease and things that are impacting health span and lifespan ultimately can come down to and trickle down to mitochondria, which are powerhouses of our cell, might actually not even be from us. That's a whole different story evolutionarily, but very important to understand that we have to keep our mitochondria healthy in order to have a healthy lifespan and a health span, from cognitive to cardiovascular disease. So understanding the cholesterol synthesis is one part. Now we have cholesterol absorption or reabsorption. So this is an enterocyte, a very fancy drawing of an enterocyte. And on one side, we have the lumen. This is our lumen of our gut. This is really the interaction between the outside world, because our gut is our essentially outside. It's a tube that starts from the top to the bottom. And then it interacts with our microbiome, it interacts with our enterocytes, the mucin that layers our enterocyte. All of these things have an impact. So if we don't really focus on that part, we're doing ourselves a disservice. But what's important to understand is that we have cholesterol transporters, or we have transporters, Niemann-Pick C1-1, and then we have ATP binding cassette G5 and G8. So this is involved with cholesterol reabsorption. Most of this happens in the, it can happen in the enterocyte. Most of it happens in the enterocyte, but some of it can also happen in the biliary system. So in the liver and the bile. But most of it is happening in the lumen. So we can inhibit how much cholesterol we reabsorb, and then we can also impact how much cholesterol we export, or efflux. So influx and efflux. So we have a medication, which is outlined here, and we'll talk about some interventions later, which can inhibit the influx. So it inhibits MPC 1-1, which will essentially prevent any type of cholesterol from being absorbed. What's important to understand is that the cholesterol that we eat, there's esterified cholesterol, and then there's free cholesterol, or unesterified. A majority of the cholesterol that we eat, this is a very important topic, cholesterol esters, which are found mostly in the food, specifically eggs, shellfish, etc., are esterified. They have a bond, or they have an attachment, an esterified bond towards the tail end of the cholesterol, which impacts its absorption. In short, it's too big. Esterified cholesterol is too big to be absorbed by itself. So it must go through a process, through certain lipases, to break that bond and allow it to become free cholesterol and become absorbed. A majority of the food in our diet majority of the cholesterol in our diet is esterified. So this whole idea that eggs cause cardiovascular disease because of the increased cholesterol, or don't eat too much cholesterol, or don't eat too many eggs because you have high cholesterol, completely invalid. And we don't absorb a majority of that cholesterol. So what's important to understand is that it's the free cholesterol that's metabolized that is brought back into the body, that is the problematic cholesterol. So most of this cholesterol that's being reabsorbed, that's inhibited, is oftentimes after the liver has moved it to the bile and has re-entered the lumen to be reabsorbed. So ezetimibe or other medications that inhibit cholesterol reabsorption are mostly working on the cholesterol, the free cholesterol that is in the bile that's supposed to be eliminated and pooped out, but it is not in many individuals, sometimes due to defects in MPT101 or ABC G5, G8. So this is a really important understanding on if we're going to intervene with somebody's hyperlipidemia, are we doing us disservice, or are we helping them by inhibiting their cholesterol? In most cases, we're not helping them very much. So, and then you can see here, ApoB48 is added in the enterocyte and then put into the chylomicron. Hypertriglyceridemia, why is it that when individuals go on a low carbohydrate diet, or if their carbohydrates are restricted, why do their triglycerides decrease? Well, triglycerides, as we said, is a glycerol with 3 fatty acids. But what you can understand through this process is that we eat carbohydrates, starch, fructose, sucrose, lactose, all of the above, any type of starch or carbohydrate that's broken down into a simple glucose, which is all of them, aside from fructose. But that can be converted, and you can see we have other versions of fructose 6 phosphate, glucose 6 phosphate, etc. As we metabolize this, we're breaking down that glucose, and through this whole process, we essentially make citrate. So from the cytosol, we then go into the Krebs cycle where citrate is built up. Once we have an overload of this glucose, this citrate then activates several enzymes, citrate lyases, which then increase production of acetyl-CoA, and then make acyl-CoA, which then go into de novo lipogenesis of fatty acids and triglycerides. So we get that glycerol mostly from the carbohydrate, but the end product, because you can see those 3 carbons, at the end product is an increase in triglycerides. This does not happen when we eat a lot of fatty acids, or fat. So it's really important to understand that this is how, because through the Krebs cycle, and we're bringing it back to biochemistry, why increasing this energy surplus, and it can be through carbohydrates, but also energy surplus is also a problem, high calories, can cause elevated triglycerides. We're going to come back to this as well, but really important to understand the biochemistry of this. Lastly, LDL particle clearance. So in the end, our liver wants to take cholesterol and eliminate it and remove it and clear it from the blood. So in order to do that, there must be LDL receptors. Those LDL receptors then bring the LDL or the lipoprotein, bring it into the into the hepatocyte, and it metabolizes it. And what happens is that as the intrahepatic pool of cholesterol increases, the body or the liver then says, okay, I'm going to make less cholesterol. I'm going to reduce cholesterol, HMG-CoA reductase. So I'm going to inhibit that. Then our LDL receptors are downregulated. So the liver says, I have a lot of cholesterol here. I don't need to increase my clearance because I have a ton here, right? So this is a negative feedback loop. And what ends up happening is that when we have too much in the serum and in the plasma, our LDL particles or our lipoproteins, and we'll get into why I'm saying LDL particles, majority LDL particles begin to build up. And this essentially is the problem when it comes to hyperlipidemia. Now we can enhance this. There's other enzymes, PCSK9, et cetera, that we can manipulate. But one way that we can also impact this is through this pathway of let's not provide as many LDL particles, and perhaps it won't have as much of an intrahepatic cholesterol pool. It's really important to understand this as we talk a lot about the interventions. But essentially, these are the processes that are happening. And many people will say, well, eating cholesterol reduces your production of cholesterol. That is true, but it's not really the cholesterol that I'm concerned about. It's in the food, it's really the lipoproteins in the plasma. So why does atherosclerosis happen? Why are we talking about lipoproteins? Because, well, first of all, it's really important to understand that there's a process when it comes to atherosclerosis. So this is the pathophysiology of atherosclerosis. You can see here, what has to happen is that we have to have apolipoprotein B, or ApoB containing lipoproteins. They need to exit the circulation and they enter the intima of of the endothelium. Once they are there, they need to aggregate, and if they aggregate, and I'm saying this very specifically, I'm very selective with the words that I'm saying, is that they need to exit the plasma through transcytosis, enter the intima of the endothelial cell, and then if they aggregate, they can form a foam cell. It stimulates an immune response, which then can cause plaque formation and subsequent inflammation. This increases the risk for or increases atherosclerosis, which can increase the risk of cardiovascular disease or coronary artery disease. What we can do is, through some treatment, is we can do a few things. We can reduce the amount of apolipoprotein B100 particles. We can improve the quality of the LDL, and we'll talk a little bit about that. Or we can help with removing these particles. And if we can do that, we can get them back into the circulation and then become metabolized. As you can see here, we have a modified LDL, which then reacts with a monocyte, which then becomes a macrophage. Through this whole process, we have a modified LDL, and we have an inflammatory response that causes a foam cell. And this is the process of a fatty streak. And it involves LDL particles or even VLDL particles, which have apolipoprotein B100 on them. And what's important to understand is that this happens in the presence of inflammation. And it's not just oxidized LDL that's the problem. It's essentially, is that LDL particle going to stick? And there's multiple different factors that determine whether it's going to stick or not. This is another image, but we can see here that inflammation is a result of and a cause of atherosclerosis. So as we cause atherosclerosis, if let's just say nothing else is going on, and just by chance an ApoB100 ApoB100 containing lipoprotein enters the intima of the endothelium, by chance it sticks, by chance that elicits an immune response or an inflammatory response. That then sets off a inflammatory cascade, as you can see here, releases IL-6, TNF, IL-1, and that causes an acute phase reactive response in the liver, which then releases more inflammatory markers such as hsCRP, ESR can go up, and that then goes back into the body, and those inflammatory markers then potentiate the inflammatory response, which then potentiates the atherosclerosis. So it's a vicious cycle, but we can stop it. Nothing else from this lecture. ApoB containing particles are necessary but not sufficient in the pathogenesis of atherosclerosis. It's very, very important. So what do we want to measure? This is the basic lipid panel. Now, could you get a lot of information from this? Absolutely. There's a lot of information that you can get from a basic lipid panel. LDL cholesterol, always label it with LDL-C. I'll explain why. Triglycerides or triacyl glycerides, depending on where you were taught or what terminology you're using. But understand that total cholesterol is the accumulation of all these, right? So LDL cholesterol is a concentration, HDL, VLDL-C are concentration. And you can see what makes them up. But most of the time we're measuring these markers. And understanding that LDL-C and HDL-C are concentrations to measure mass. So LDL-C and LDL-P, LDL particles, are different. They don't often correlate. They're sometimes discordant, and we see that in a lot of larger data sets like the Framingham study and the MESA population. So we can see that all of those two markers don't always correlate, or not concordant, as we would say. And then we can measure ApoB, and ApoB measures all ApoB containing particles. So it is measured in milligrams per deciliter, but it's really measuring particles. And we know that there's one ApoB per LDL particle. So if we can measure total ApoB, then we can also get an idea of the LDL particles. And we understand that that is most important with cardiovascular risk. This is our advanced lipid panel. And some of this is included in your basic lipid panel. But when you look at ApoB, that is going to be the biggest bang for your buck. If it's one test, it's going to be ApoB. But LP little a, or lipoprotein little a, is going to be very important as well, because it's a significant risk factor, and you only have to do it once. So it's not going to change. At this moment, we don't have medications that can impact or have a reduction in lipoprotein little a. Some may argue that PCSK9 inhibitors may, and in some people that they do, but that's not across the board. But other markers that we're going to look at, desmosterol and lithosterol, which we discussed in cholesterol synthesis, cytosterol and campestrol, which help with reabsorption. So that's going to be talking about with the medications that inhibit reabsorption. And then we can look at other things like oxidized LDL, ApoA1, oxidized phospholipid ApoB, HDL particle and particle size, and LDL particle. We're going to talk a little bit more about the ones on the left, because the ones on the right, although they're important, they don't really give us a lot of information on risk assessment relative to what those on the left can give us. So as I already discussed, ApoB is probably going to be the most important, especially when it comes to reducing cardiometabolic disease risk and dementia risk. If only one test can be done, we already said it would be ApoB, and about 95% of your ApoB containing lipoproteins are LDL particles. So remember, in the end, it comes down to the clearance of these ApoB containing particles, regardless of anything else. We looked at the physiology of desmosterol and lithosterol, and if we can measure those, then we can talk about, well, if those are high, then we know that cholesterol synthesis is high, and what can we do to intervene or perhaps reduce those? And what we see is that those are responsive to statin therapy. So almost always, if you give somebody a statin, their desmosterol and lithosterol will decrease. And they also are responsive to saturated fat. So it's possible that saturated fat intake can cause an increase in cholesterol synthesis. It also causes an impact on cholesterol clearance, which we'll talk about. But this allows one to hypothesize or guess or assess what would be the best intervention for this individual. It's a personalized approach to lipid management. Again, bringing us back to our lithosterol and our desmosterol. If we can inhibit those, try to get those down, and we're essentially bottlenecking the pathway and preventing cholesterol from being synthesized in the liver, which then will give less cholesterol for the liver to incorporate as a lipoprotein. And we see a reduction in ApoB and LDL-C. So we talk about interventions. These would be statins. Other ones, if you're not prescribing, would be red yeast rice, monocolin K, and other natural monocolins found in red yeast rice. So not just the active statin, I should say, a natural statin in red yeast rice, actually have other inhibitory action. So it's not just, this comes down to like the synergistic effect of nutrients, that when you isolate it, perhaps has one effect, but when you combine it with its naturally occurring micronutrients or nutrients or phytonutrients, the effects are potentiated. And then you could see here, saturated fat reduces LDL clearance. So essentially, adding more saturated fat decreases the transcription of LDL receptors. And that means you're having less LDL receptors on the liver, which means less saturated fat is cleared, or excuse me, less lipoproteins are cleared. So one way that we can assess or impact cholesterol synthesis and LDL clearance is with saturated fat. But there's other factors that are involved, and that's why this is a cardiometabolic disease, not just cardiovascular. This is just for your information. You can look at some of the relative doses of statins, and usually red yeast rice, it's 1.8 to 2.7 grams, and that usually is equal to about 20 to 40 milligrams of lovastatin, usually towards the lower end. Some people respond excellent to red yeast rice, some people don't. You really have to assess their individual makeup. Then we talk about reabsorption markers, campestrol and cytosterol. These are phytosterol, beta-cytosterol. So you want to be careful with individuals who are taking phytosterols, like if they're taking a prostate formula, or if they're taking a formula for their hair, or if they're eating a lot of phytosterols. You'll see that, although I haven't seen anybody eat so much that it causes elevations, it's mostly from supplementation. If they're doing those things, then you can't say if they're reabsorbing a lot of their cholesterol or the cholesterol in their gut. So these are responsive to cholesterol absorption inhibition, and that could be from medications like ezetimibe, but although other nutrients can impact cholesterol absorption, if assuming it is a free cholesterol, and that would be soluble and insoluble fiber. So you want to have a mix of the two so we can bind it and pull it out. There's other medications that are used, cholestyramine. Those are not really used today for cholesterol or lipid management, but does have that cholesterol inhibiting, absorption inhibiting effect. This is less likely to respond to a saturated fat diet, aside from individuals who are on high fat diets. So I would say a majority of the patients that I see who are keto or high fat almost always have elevated camptosterol and sitosterol, along with desmosterol and laethosterol, because it causes such an influx, and you'll see this in that population. So it's very hard to assess. And one thing I would mention is that if you're going to intervene with cholesterol synthesis, you want to make sure you don't reduce desmosterol too low, because we need cholesterol for the brain. And if we inhibit it way too much, it can have a negative impact, we suspect, on cognitive function. And that's largely because the levels of desmosterol in the blood correlate with CSF desmosterol. So you just want to be careful if you're over-suppressing desmosterol. So these are some interventions that we discussed for cholesterol reabsorption, ezetimibe, and soluble and insoluble fiber. Important to talk about lipoprotein a, not lipoprotein A, and it's codominant inheritance, kind of like blood type. So some people might have a very, very high level, some people might have a low level. Usually I use a cutoff for around 50. And if individuals have elevated lipoprotein a, immediately their risk goes up. Number one, we know that their risk for aortic stenosis increases. Other things are, we thought that perhaps lipoprotein inhibits or prevents fibrinolysis, which was by acting as a plasminogen inhibitor, but it doesn't seem to be the case. We thought it perhaps caused more clotting or caused more atherosclerosis because of that inhibitory plasminogen effect. It doesn't seem to be that that's the case with a lot of the literature. So it just so happens that there's another way or reason why Lp(a) is having an impact on cardiovascular risk. I would advise almost everybody get this done once in their lifetime, especially in individuals who have a family history of early onset cardiovascular disease. For example, my father had 2 heart attacks at the age of 47, and I tested my Lp(a), and I will test it in my children, and so on. It's a very important marker to assess. Then we look at LDLP or LDL particle, very different from LDLC. If we're really going to talk about what's most important, I would put ApoB as number 1 and LDLP as number 2. What's really important to understand is LDL particle size is a better indicator, not really for cardiovascular risk. That really, the winner there goes to ApoB, but it's a very important assessment for insulin resistance. So, and we're going to talk a little bit about triglycerides and why that actually matters. But when we have small, dense LDL particles, that means we have very large VLDL particles, or most case we do, which also means that we likely have elevated triglycerides. So that is an indication of insulin resistance. In the end, you don't want small, dense LDL, and you don't want very big VLDL. And that's often a function of your insulin sensitivity and triglyceride levels. This where I think a lot of important information should be focused on is if these triglycerides become incorporated into chylomicrons and VLDL particles. And if you go back to one of the earlier slides where I showed that as cells get smaller, the triglyceride content decreases and the cholesterol ester increases. So from chylomicron to LDL, the LDL are not triglyceride-rich lipoproteins, whereas chylomicrons are. If we have elevated triglycerides, that means we have more triglycerides in our chylomicrons, we have more triglycerides in our VLDL through multiple different processes where we think HDL is the one involved in transporting cholesterol. VLDL can also exchange cholesterol esters and triglycerides with LDL. So we thought that the only thing that can interact or have reverse cholesterol transport was HDL, but in fact, that's not true. Actually, LDL does as well. So if you have a lot of VLDL with a lot of triglycerides, you're going to exchange them via an enzyme called PETP, and it can exchange it with LDL particles. So now those triglycerides are going from our VLDL to our LDL. So now our LDL particles become triglyceride-rich LDL particles or ApoB lipoprotein containing particles. And that essentially what it does is it impairs ApoB clearance. So that inhibits lipoprotein lipase, that inhibits the structure of these lipoproteins. So it's harder for them to bind to receptors. And that causes these LDL particles and the VLDL to exist longer in the plasma, which then increases the resonance time, which then increases the area under the curve, which then increases exposure, which then increases the likelihood of these ApoB proteins, lipoproteins, entering the intima of our endothelium, which then increases the likelihood of there being an inflammatory response, which then contributes to atherosclerosis. What's important to understand is that 150 milligrams per deciliter of triglycerides is the 75th percentile. So that's what's considered to be normal, but it's absolutely not normal. And we'll talk about some of the guidelines here. This is another picture that shows that when you have individuals with a high plasma triglyceride level, this is their clearance of their lipoproteins or their LDL particles. And you can see that they actually extend for quite a while and they're elevated for over time. Whereas somebody who has low triglycerides, they clear those LDL particles fairly quickly. And that's a good thing. We don't want them in the plasma. And this is average. These are some interventions for elevated triglycerides. I can argue that nutrition is probably the best intervention. And we find that fibrates usually work in people who are more insulin resistant. So fibrates inhibit ApoC3, and ApoC3 inhibits LDL cholesterol or lipoprotein lipase. So essentially will cause an increase in the residence time. So fibrates help us clear these particles better, but nutrition can also have a very good effect as well. So in the end, we want to improve LPL activity, lipase, we want to induce lipolysis. But what's the one thing that inhibits lipolysis? Insulin. Insulin levels will directly inhibit LPL on our muscle cells. The one thing that doesn't inhibit it on is on our fat cells. So our muscles are not using it. They can't take the fatty acids. They go to the fat cells, and then the fat cells become a problem and they get engorged. So in the end, it's really about addressing dietary factors. This brings us back to why carbohydrates are important. What's important to understand is that triglycerides are more sensitive to postprandial elevation. So triglycerides should be done fasting. LDL particles, ApoB, really doesn't matter because they have a residence time of about 3 to 5 days. So assuming you weren't eating poorly for 5 days, what you ate this morning, what you ate yesterday is very unlikely to have an impact on your LDL particles or your LDL-C or your VLDL or your ApoB. So if you have to take somebody's ApoB in the afternoon, that's okay, but don't take their triglycerides. These are some metabolic markers, which are very, very important. And this brings us back to the whole discussion of cardiometabolic disease. Triglycerides are a big gateway to this conversation. But what we want to understand is that fasting blood glucose and hemoglobin A1C are not really useful unless you're full-blown diabetic. And then they become a problem. Fasting blood glucose may be a little bit more, but the goals, I would say, to really assess insulin resistance at an early state would be LDL particle size, VLDL particle or VLDL-C. So more VLDL would be a problem because you would assume that they have more triglycerides, small dense LDL particles, and then these three markers, insulin, CGM, and OGTT, oral glucose tolerance testing. These are essentially the gold standard. Really, OGTT is the gold standard for insulin resistance.